I wanted to finish just by asking you about the role of molecular medicine, and in particular deep sequencing or next generation sequencing in patients with MDS. And is that something that you're performing, or is that something you're acting upon, or how do you incorporate that in your care of the patients?
So I want to answer that by taking you through really what happens to a patient who is now an older individual around 70 years of age or older and suddenly presents with a cytopenia. One of the first things that you think about is, after you've ruled out all the other nutritional and drug-related and infection-related causes, then you start to worry that could this be a primary bone marrow disorder. You go ahead and do a bone marrow, and the bone marrow is unequivocal. I mean, it doesn't show, it doesn't meet the minimal diagnostic criteria for MDS. And that minimal diagnostic criteria is at least 10% cells have to look dysplastic, or there has to be a cytogenetic abnormality, or the blast count has to be between 5 and 19%. That's the minimal patient's bone marrow doesn't meet any of those. So now we label the patient as having ICUS, idiopathic cytopenia of undetermined significance. Now, in this day and age of molecular profiling, we go ahead and send a test for genetic profiling. It comes back as showing, let's say, an ASXL1 mutation in 32% of the cells. Now what do you call it? Is it MDS now? No, of course not, because MDS minimal criteria are not met. But the patient's disease gets upgraded from ICUS to CHIP, and CHIP stands for clonal hematopoiesis of indeterminate potential. So now you know there is a clone of cells because of the presence of this mutation, but yet you can't call it MDS, which I find surprising, because if there was a cytogenetic abnormality, we could call it MDS, but because there's a genetic abnormality, we don't call it. Anyway, so now we have ICUS to CHIP, and then what is the potential of this to develop into MDS? 3,000 patients followed with ICUS at Mayo Clinic. 60% of them ended up developing MDS, 20% developed an non-MDS related neoplasm, and the other 20% really nothing. So it's not a good thing to have ICUS, because 80% will end up with either MDS or another malignancy. Having CHIP, what does that mean for developing MDS? We really don't know right now. Now let's say you have a patient who's fully diagnosed with MDS, and now you do a molecular profile, and now you are looking for the 40 or 50 or 100 most commonly myeloid disease related genes, and you find 1, 2, 3, or 10 mutations. What do you do with this information? Does it affect your treatment? So in 2011, we published a paper in New England Journal of Medicine, which showed that if there is any mutation in one of 5 genes, which is P53, EZH2, ASXL1, I think it's TET2, if there's any mutation in one of these 5 genes, then survival is actually compromised. However, with time, we have learned more that, for example, if there is a patient who has ring sideroblasts, but who now has an SF3B1 mutation, then that survival of that patient is likely to be better than having ring sideroblasts and no SF3B1 mutation. Then we know that other splicing factors like SRSF2 or U2AF1, these are related with a compromised survival, no matter what type of MDS they have. So those are important. Then we have certain targetable mutations. For example, 5 to 10% patients with MDS can have a mutation in IDH1 or 2.
Right.
And for those, we have oral inhibitors available. For those patients, in last 6 months, James, I must have had 10 patients diagnosed with who are showing IDH1 or 2 mutations that we were able to treat with the drug. So I think that's an important thing. Then those patients who have isolated TET2 mutations are likely to respond better to hypomethylating agents. Their response rate is 85%,
right,
compared to 50% for the rest of the population. So I think P53 is the most important. Most commonly, P53 mutation is present in association with a complex cytogenetics. So if multiple chromosomes are damaged, P53 is mutated, median survival is 6 months, everyone is dead by 2 years in our study. That is not a good combination to have. On the other hand, if a patient has multiply damaged chromosomes but no P53 mutation, their median survival is over 3 years, and many of them are living up to 8 years and 9 years. So in other words, genetic trumps cytogenetics here, because P53 seems to be much more important than. So my answer to your question, very long-winded, is about genetic profiling and its role in MDS is that MDS is not one disease. We go from ICUS to CHIP to MDS, which is all these different types, and all types can have one or more of the mutations. It's a very important time for us to follow these mutations to measure their clonal velocity. At what rate is each mutation likely to progress, either in isolation or in association with other mutations? All these data need to be collected and cataloged over the next few years so we can start incorporating it into developing more accurate prognostic classification systems and as guides for future therapies.
Well, that's an excellent answer, and we've had a more cautious approach to them. We know that some mutations like ASXL1 may predict for a shorter response duration with azacitidine, for instance. But it doesn't stop us from using azacitidine. We still think you do better on it than off it.
Yes.
So that I would caution other practitioners not to use it. Sometimes it'll guide therapy. Sometimes it'll move you more to a transplant strategy. Or I think it teaches us a lot about the pathogenesis or pathobiology of the disease. But how to exploit it in individual patients will require better therapies and more therapies. And I like that you're using it to try to identify the small subset who can be targeted with inhibitors for that small subset with IDH1 or IDH2 mutations as an example. Yes. So,
I did want to say one other thing, James, which I forgot to say, the importance of P53 mutation at the other end of the spectrum. So I only talked about so far the importance of this mutation in the presence of a complex karyotype. At the other end of the spectrum are patients who present with an isolated deletion 5q. These patients are supposed to have generally a more benign disease, low incidence of transformation to acute myeloid leukemia. Yet we find that a good 18% of them can have a P53 mutation. And if that mutation is present, then their chance of rapid transformation to AML is high. Interestingly, not the response to lenalidomide, which is the same as non-P53 mutated, but doesn't last that long. And they can progress to acute leukemia. And for that patient, you need to consider a transplant option earlier if they are good candidates. So what I'm saying is, when I say that genetic trumps cytogenetics, I'm saying that that's true for both ends of the spectrum. For disease that looks dreadful with multiply damaged chromosomes, and on the other hand, for disease that you could be lulled into a complacency and tell the patient everything is hunky-dory, come back in 6 months. No, because if with that isolated deletion 5q, they have a P53 mutation, you may have to start planning for alternate therapies.
It's a tricky area. You know, you have these abbreviations of ICUS and CHIP, and then we get to MDS. And there's another one called ARCH, the age-related clonal hematopoiesis in well people with very low level or very low variance allele frequency mutations that predicts a higher risk for disease, and yet most people still don't get disease. So that until we have enough information on how to really act upon these and more targeted therapies, I think it has to be incorporated into the standard diagnostic testing and algorithms. Well, I'm going to